Can you see my slides now?
Yes, we can at Lincoln.
Hello, can you see my slides now?
Yes, we can at Lincoln. Yes.
Right. Okay, thank you. So connective tissue diseases, actually, it is a group of the diseases which has some similar clinical manifestations. Joint pain, renal phenomenon, rashes, involvement of the lung, muscle, something like that. Today, I'm going to more focus on clinical approach rather than the theoretical backgrounds. You can read at like Oxford Handbook of Rheumatology if you need further information, or I can provide you with more information if you need more theoretical background. I understand that some of you might already finish MRCP, or some of you are preparing for the MRCP exam. So I'm preparing more for the clinical based approach rather than the theoretical base. So today I'm going to touch a little bit about lupus, antiphospholipid antibody syndrome, Sjogren, systemic sclerosis, MCTD, mixed connective tissue diseases, inflammatory myopathy. Some of the textbook doesn't include inflammatory myopathies and connective tissue diseases, but for the benefit of the clinical practice and for the exam purpose, I included inflammatory myopathy. After that, I will go to history taking, relevant physical examination, investigation, and the treatment in general. So start with the SLE. So usual manifestation is like fever, but SLE rarely present with daily high intermittent fever, and then SLE does not present with chills and rigor as well. So we suspect infection in patient with lupus when presenting with intermittent high fever with chills and rigors. They can present with non-scarring alopecia, but actually it is very common in daily practice. Usually it is seen in 70% of the population. Oral ulcer, usually they are painless. It can be in the oral cavity, especially at the high palate. And then sometimes it can be nasopharyngeal as well. It is seen in 50% of the lupus patient. Subacute cutaneous or discoid lupus, I will show you the photos after this slide. The very common malar rash is categorized as acute cutaneous lupus. They can present with photosensitivity. The rashes are more prominent under the sun. And next common presentation is a joint manifestation. They can present with synovitis. Synovitis means inflammatory arthritis together with a joint swelling, or inflammatory sounding joint pain. The patient can have joint pain with prolonged morning stiffness. Usually pain improves with activity. Or actually, SLE is a multi-system organ disease. It can affect almost everywhere in the body. Pleural effusion, interstitial lung disease, diffuse alveolar hemorrhage. It is usually a rheumatological emergency. Sometimes it can seen in the MRCP Part 2 exam as well. Lupus patient, high disease activity, presenting with cough, breathlessness, hemoptysis, and then some shadowy changes in the X-ray. So we need to think about diffuse alveolar hemorrhage. Cardiovascular system, so it can affect almost all layers of the heart. Pericarditis, pericardial effusion, myocarditis, endocarditis. And in terms of neuropsychiatric manifestation, so it can affect almost everywhere in the nervous system. cerebritis, aseptic meningitis, lupus psychosis, vasculitis and a stroke, transverse myelitis, mononeuritis multiplex, peripheral neuropathy, everything. Most common manifestation is lupus nephritis. It can be seen in 50% of the SLE patient. Sometimes it might be like not that what's it called? Aggressive nephritis. Usually it can be like low-level nephritis. Hematology, autoimmune hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, pancytopenia, very common. So actually, this is the photo showing which organ system can be affected in the SLE. It can affect the eyes, uveitis, retinal vasculitis, nervous system involvement, rash, or everywhere, kidney, muscle. Sometimes lupus can cause myositis as well. So actually, lupus can affect almost everywhere in the body. This is the photo showing that non-scarring is alopecia. You can see the sparse hair, but there is no scar. Usually it is seen, especially SLE is in active condition. This photo shows the oral ulcer. You can see the ulcer in the heart belly. Usually sometimes this lesion is ignored by the patient because it is painless. So when you suspect whether the patient has oral ulcer or not, you need to look inside the patient mouth. This is a photo showing the DLE. Maybe you can see this kind of photo in the MRCP Part 2 exam. This is the discoid lupus as well. There is a scar, there is a depression, and that actually this is a discoid lupus lesion in the scalp. So it is different from the non-scarring alopecia. After the discoid lesion in the scalp, it can be scarring and it can left with like permanent lesion. So usually you might see those kinds of picture in the MRCP2 exam. This picture showing vasculitic rashes. When you see the rashes, it shows that the disease is very active, vasculitic rashes. This is the picture showing the malar rash. So the malar rash affecting the cheek, nasal bridge, and it spares the nasolabial fold. It is different from the rash seen in the dermatomyositis, and it can exhibit in the sun exposure. We call it like photosensitivity as well. This is the photo showing the synovitis. You can see there is a joint swelling here. So in summary, in patient with lupus, the patient can present with constitutional symptoms, fever, and then usual presentation is joint pain, skin rashes, and then the patient can present with features of any other organ symptom. Maybe present with pericardial effusion, pericarditis, pleural effusion, interstitial lung disease, or lupus nephritis. So any organ system can be affected. The patient can be present with seizure, features of meningitis, transverse myelitis, anything that can happen in lupus patient. So when you suspect the lupus patient, what are we going to now? So we are going to order auto antibody. I think you're already aware of this ANA and the ENA. ANA can be seen in more than 99% of the lupus patient. So if the ANA is negative, it is very, very unlikely the patient has lupus. Double-stranded DNA is seen in 70% of the patient. It correlates with the disease activity as well. We can do it as a baseline, and then repeat in a further follow-up to see the disease activity. It is very sensitive for the lupus as well. It fluctuates with disease activity. It is associated with lupus nephritis, Smith antibody. The prevalence is low, but very sensitive for the lupus. Anti-double-stranded DNA and anti-Smith antibody, very sensitive for the lupus. LAR antibody, the prevalence is low. It is also seen in the patient with Sjogren's syndrome. But sometimes you can see LAR antibody positivity in SLE patient, photosensitivity, subcutaneous lupus, neonatal lupus, and then when the pregnant SLE patient has LAR antibody positive, the newborn can be present with congenital heart block. Usually, these are very common in MRCP 1 and 2 exam. Antihistone antibody is seen in a drug-induced lupus. Antiphospholipid antibody, I think you're already aware that it can present with arterial and the venous thrombosis and the pregnancy morbidity. So these are the ANA and the ENA you can find in the patient with lupus. This is the most recent American College of Rheumatology and European Association for Rheumatology, ACR, EULAR guideline classification criteria for the lupus. It is not a diagnostic criteria, it is the classification criteria. So maybe SLE patient with transverse myelitis, we can diagnose as SLE, although transverse myelitis is not there in this classification. So it is just for the research purposes. So to be classified as lupus patients, the entry criteria is positive ENA. And if the ENA is positive, and then we look for clinical domains and then laboratory domains. There are clinical domain like fever, other neuropsychiatric feature, mucocutaneous feature, serosive feature, musculoskeletal feature, and then it includes the investigation result as well. You can see that if the complement protein is low, it adds some points into the classification criteria. That is why we request the complement protein when we suspect one patient has lupus. Do you have any questions so far? Okay, so I'm going to move to next section. Antiphospholipid antibody syndrome. It is the triad of thrombosis, pregnancy loss, and the presence of the antiphospholipid antibody. So when are we going to suspect one patient has antiphospholipid antibody syndrome? Arterial thrombosis at young age, unprovoked venous thrombosis at young age, recurrent thrombosis, simultaneous arterial and venous thrombosis in the same patient, and thrombosis at unusual site like renal thrombosis, hepatic vein thrombosis, cerebral venous sinus thrombosis, mesenteric thrombosis, retinal thrombosis. You are going to see such a question in MRCP 2 exam. Patient presented with unusual presentation, what blood tests you are going to request or something like that. And this patient has previous history of pregnancy loss. So you need to suspect antiphospholipid antibody syndrome. So in terms of obstetrical, it is fetal loss or recurrent miscarriage, unexplained fetal death beyond 10 weeks, premature delivery due to preeclampsia, or if it is early miscarriage, it should be more than 3. These are the obstetrical manifestation. So in terms of investigation, which lupus and which antiphospholipid antibody we are going to order? We order lupus anticoagulant, anticardiolipin antibody, IgG, IgM, anti-beta-2 glycoprotein 1, IgG or the IgM. It should be positive in 2 or more occasions, which are repeated 12 weeks apart. So we need to confirm that this antibody is persistently positive. As these kinds of antibody can be seen in a patient with like infection. That's why we need to exclude the patient is not having the infection. And then I'm going to move to Sjogren's syndrome. It is a triad of dry eye and a dry mouth, fatigue, and a joint pain. So this is the picture showing the poor saliva pooling in the patient with Sjogren's syndrome. So when you suspect patient has dry mouth, we need to look and the site under the tank to look for the saliva pooling. In the normal people, we see some saliva pooling, but in the patient with Sjogren's syndrome, when the mouth is very dry, the saliva pooling is not that brilliant. And then when we ask them further questions, maybe the patient gives the history of dental problem because, you know, we need some saliva for their dental hygiene. So the patient will complain of recurrent visit to their dentist, and then they might have some poor dental hygiene or some dental decay as well. Actually, this is also a tongue showing dry mouth. So this is the picture showing the Schama test. The patient has dry eye, the patient has dry mouth. So we need to prove that. So how are we going to prove the patient has dry eye? We call it, this is the Schama test. We put a piece of the paper with some measurements into there and the side of the lower conjunctival sac, and then look through the saliva flow after 5 minutes. If the saliva flow is less than 5 millimeter, the Schama test is positive. Because Sjogren's syndrome is a disease that affects the exocrine gland, sometimes the patient can present with parotid swelling. You can see the patient having some parotid swelling. However, dry eyes and the dry mouth are very common in normal population. Dry eye, it is seen in aging patient on diuretics, anticholinergics, antidepressant, previous surgery, hepatitis C, HIV infection, other diseases. Similarly, the dry mouth as well. So whenever the patient complain of dry eye and the dry mouth, we need to ask the drug history as well, because it is very common, especially when the patient is on like, on a tricyclic antidepressant like amitriptyline, sertraline. They are very common. So the manifestation, two manifestation, exocrine gland involvement, parotid gland swelling, so extraglandular involvement, arthritis, nervous system involvement, interstitial lung disease, in renal tubular acidosis, and the patient can present with severe hypokalemia. You can see such scenario in MRCP2 exam. Patient has history of dry eye and the dry mouth, presenting with severe hypokalemia. Sometimes you need to think about Sjogren's syndrome with renal tubular acidosis. Interstitial nephritis, cutaneous vasculitis. This is the picture showing cutaneous vasculitis. There is a chance of lymphoma because Sjogren's syndrome affects the B cell. Sometimes the patient can present with lymphoma. These are the typical laboratory findings. ANA 90% prevalence, rheumatoid factor 50%. So if the patient present with positive rheumatoid factor and the joint pain and the joint swelling, it could be rheumatoid arthritis or it could be Sjogren. Sjogren's syndrome, actually, it's more common than rheumatoid arthritis. Rular antibody positive, elevated ESR is very common because there is association with hypergammaglobulinemia, anemia of the chronic disease, Sometimes present with leukopenia, thrombocytopenia, it's a bit rare. Next, I'm moving to systemic sclerosis. This is a triad of vasculopathy, immunology, and the fibrosis. So in terms of vasculopathy, renal phenomenon is very, very common. More than 90% of the patient has renal phenomenon. Sometimes it starts with renal phenomenon for many years and then later develop systemic sclerosis. So if you suspect systemic sclerosis and the patient does not have renal phenomenon, it is doubtful that whether it is really a systemic sclerosis because it is very common in systemic sclerosis. And in contrast to the primary renal phenomenon, it can result in tissue ischemia and a tissue damage. The patient can present to progress to digital ulcer, digital gangrene, pulmonary arterial hypertension, and scleroderma renal crisis. This scenario is also common in MRCP2 exam as well. Systemic sclerosis patient, acute renal failure, recent introduction of some steroids. So it is also a common scenario as well. Fibrosis. Fibrosis everywhere in the patient body. Skin fibrosis, interstitial lung disease, fibrosis in the GI tract, presenting with dysphagia, difficulty in swallowing, bloating, indigestion, pseudo-obstruction, anal incontinence, everything. Myocardial fibrosis. So fibrosis everywhere. The hallmark of the systemic sclerosis is fibrosis. Immunology. When we test the immunology, positive ANA, anti-SCL70 positive, anti-centromere, anti-RNA polymerase 3. Anti-RNA polymerase 3 is usually associated with like scleroderma renal crisis. So if you find the patient antibody, anti-RNA polymerase 3, please be aware of the scleroderma renal crisis. I'm showing the picture of the nasal capillaroscopy. Because the patient has vasculopathy, there is one place in our body that we can check the capillary. It is called nasal capillary. It is actually looking at the patient navel under the microscope. So these are the changes seen in a patient with systemic sclerosis. So normal navel is like hairpin appearance. In a patient with systemic sclerosis, there are a lot of changes. The capillaries are giant. There are lots of capillary. There are new angiogenesis. There are hemorrhages. These are the abnormal navel features found in the patient with systemic sclerosis. This is the photo showing Raynaud's phenomenon. This is the photo showing the digital ulcer. If the digital ulcer is healed, it results in digital scar. We call it digital pits as well. And sometimes it can result in digital gangrene. So in contrast to primary renal, the primary renal is usually early onset, precipitated by the cold or emotional stress, bilateral symmetrical attack, and there is no tissue necrosis of the gangrene. So in a systemic sclerosis patient, the renal phenomenon can result in necrosis of the digital gangrene. But primary renal phenomenon never present with tissue necrosis of the gangrene. These are the picture showing sclerotectily and then showing skin necrosis. Maybe you might see this kind of picture in the MRCP2 exam, like fish mouth appearances with some facial telangiectasia. So patient have features of interstitial lung disease. Patient can present with cough, breathlessness. This is an MRI scan showing myocardial fibrosis. In fact, this is an endoscopy of feature found in a patient with systemic sclerosis. We call it watermelon stomach. This is gastric antral ectasia. Patient can present with anemia. So these are also features found in the systemic sclerosis, especially with GI manifestation, dysphagia, GERD, gastroparesis, small bowel bacterial overgrowth, colonic pseudo-obstruction, anal incontinence. The main thing is fibrosis everywhere in the body. Mixed connective tissue disease. Mixed connective tissue disease is the disease with some features of lupus, rheumatoid, myositis, or systemic sclerosis with positive U1 RNP. The patient cannot directly categorize into specific diseases. The patient presents with some swollen hands, synovitis, myositis, renal. The patient cannot be categorized into specific connective tissue disease. We call it mixed connective tissue disease. The patient can have interstitial lung disease, pulmonary hypertension, myocarditis. Inflammatory myopathies, polymyositis, dermatomyositis. We now have new diagnosis of necrotizing autoimmune myopathy. It can be paraneoplastic in 10%. So when you see the patient with inflammatory myopathy, you need to screen for the malignancy appropriate to their age. So the triad is proximal muscle involvement, pharyngeal muscle involvement, respiratory muscle involvement. In patients with dermatomyositis, we can also see some rashes. How do we diagnose the patient? MRI of the muscle. You can see some muscle edema showing some inflammation. Nerve conduction study, EMG, showing some parts of fibrillation potential. Muscle biopsy, muscle enzymes. And now we recently have myositis specific antibody. There are a lot. I will tell you a little bit about myositis specific antibody, like anti-MDA5 found in the patient with dermatomyositis, very progressive interstitial lung disease. If the patient is positive for anti-TIF1 gamma, you need to specifically screen for the malignancy because it is highly likely that the patient has underlying malignancy. Anti-Jo1, PL7, PL12 usually associated with interstitial lung disease. So myositis specific antibody, they are useful in categorizing what type of manifestation these patients have. These are the photos showing patient with dermatomyositis. You can see some malar rashes. However, there is also involvement of the nasolabial fold. In contrast to that, malar rash of the lupus. This patient presents with heliotrope rashes, erythematous and lilac rashes around the eyelid. Sometimes it can be associated with eyelid edema. This is Gotron papule, erythematous, some scaly rashes over the knuckles. This sign is also called shawl sign, erythematous rashes around the knuckles and around the shoulder. It is like wearing a shawl. That is called shawl sign. This picture you will see in the MRCP2 exam. So the complications are interstitial lung disease, diffuse alveolar hemorrhage, cardiac involvement is found in 30% of the patient, although most of the time patient can present with skeletal muscle manifestation, malignancy. Do you have any questions so far? Okay, so I've just touched a bit of some common connective tissue diseases. Lupus, Sjogren, systemic sclerosis, mixed connective tissue diseases, inflammatory myopathy. So these are the common manifestations: joint pain, skin rashes, dry eye, dry mouth, renal, skin problem, muscle weakness, fatigue, constitutional symptom plus systemic symptom. So when you suspect one patient has connective tissue diseases, you will need to ask those kinds of questions. These are the some common manifestations. Lupus can affect almost all systems: Sjogren, CNS, respiration, but Sjogren rarely affect cardiovascular system, GI. It can progress to lymphoma, systemic sclerosis. There is no nervous system involvement. Major manifestation is ILD. Sometimes it can present with myositis. So inflammatory myopathy, no involvement of the nervous system. GI, sometimes maybe present with dysphagia, but not really the GI tract. Because it affects the pharyngeal muscle, the patient can present with dysphagia, choking, aspiration. There is no renal involvement in patient with inflammatory myopathy. Muscle involvement, it never involve hematological systems. If there is involvement of the hematology system, the patient might have some overlapping features with other connective tissue diseases. So these are the some systemic features common in mixed connective tissue diseases. So common scenario in MRCP exam: joint pain and a facial rash, cold finger with difficulty in swallowing, dry eyes, fatigue, breathlessness, fatigue. It could be lupus, it could be Sjogren, it could be systemic sclerosis, or it could be inflammatory myopathy. But when you ask the history from the patient, you need to include there's some salient feature, although the scenario present with joint pain and the facial rash, you need to ask renals, dry eye, dry mouth, breathlessness, fatigue, everything, because sometimes they can overlap with each other. So I'm going to talk about history taking. So starting from the joint pain, onset, course of the pain, distribution, symmetry, because our connective tissue diseases are presented with inflammatory arthritis. Usually it is symmetrical. Duration of morning stiffness. Has the patient noticed joint swelling, improve with activity, and then ask for a rash? Where is the distribution? It is over the nose, over the cheek. Where is it? Is it at the light sun exposed area? That sunlight precipitate to aggravate the rash? We are asking the photosensitivity. Oral ulcer, distribution, is it painless or the painful? History of excessive hair loss. So in terms of dry eye, as the dry eye is very common, we need to ask specifically about the severity of the dry eye. Have you had daily persistent troublesome dry eyes? Recurrent sensation of the sand or gravel in the dry eye? Otherwise, if you ask the patient, do you have dry eye? Patient will reply with that, yes, I have dry eye. Because it is very common symptom. Do you have sore eyes or difficult wearing contact lens? Do you use the TR substitutes? How many times per day? You need to ask. Very detailed. Dry mouth. Have you had a daily feeling of dry mouth for, how many months? Do you need to drink liquids to aid in swallowing? Do you have any difficulty eating the dry food, especially like cracker? Because, the cracker or potato chips, they are dry food. If the patient has troublesome dry mouth, they cannot eat potato chips or the cracker. It is called cracker sign, Do you wake up at night with a dry mouth and have to take sips of water? All the question asked specifically about dry eye and the dry mouth, history of tooth decay, history of dental problem, history of frequent visit to the dentist. These are the common symptoms. Have you noticed any parotid swelling, swelling in the face, Raynaud's, age of onset? So if it is primary Raynaud, usually it starts at less than 40 years of age. Are your finger usually sensitive to cold? Do your finger change in color? Do they turn white, purple, or both? If the patient is not sure about that, you can show the patient the picture from the Google, like showing some Raynaud's distribution. Is it at the toes, ears, nose? Is it unilateral or bilateral? Severity of the attack, history of digital ulcer. And then if the patient presents with renal phenomenon, single digit, asymmetrical distribution, associated with arm colligation, please beware of the other condition rather than systemic sclerosis, like thoracic outlet syndrome, like atherosclerosis, Buerger disease. So in terms of muscle weakness, onset, usually onset is acute or subacute in patient with inflammatory myopathy. Functional consequences, get up the stair, and can she brush at high, something like that, difficulty in swallowing. So these are the usual questions we will need to ask if we suspect a patient has connective tissue diseases. After that, we can add systemic symptom, cardiovascular symptom, chest pain, palpitation, cardiovascular system, respiratory system, GI, renal, constitutional symptom. So these are the common symptom, usual symptom we should ask when we suspect the patient has connective tissue diseases. Past medical history is important. Maybe patient has history of blood clots, history of miscarriages. Surgical history is also important. Drug history is also important, especially patient has dry eye, dry mouth, renal. We need to check whether the patient is on beta blocker, muscle weakness. If the patient is on prolonged steroid, the patient can present with proximal myopathy. Occupational history is also important. Family history of autoimmune diseases, social history. So these are the history we'll need to ask in patient with suspected connective tissue diseases. Physical examination, I've already shown you photos that can be seen in a lupus, Sjogren, dermatomyositis. So we need to check whether patient has broad swelling, malar rash, discoid rash, heliotrope rash, saliva pooling. Look for synovitis, sclerodactyly, vasculated rash, digital ulcer, Gottron's. Actually, it will be based on what you suspect after the history taking. So it will be like system focus. Listen to the heart and the lung, feel the abdomen, check for muscle power. If you suspect the patient has inflammatory myopathy, look for leg edema. If you suspect patient has renal problem. So after that, we are going to do some investigation. So we are going to start from the basic investigation, request the full blood count. We will check whether the patient has anemia, leukopenia, lymphopenia, thrombocytopenia. If we find these abnormality, we will suspect lupus, Sjogren, or MCTD. Inflammatory myopathy, systemic sclerosis, they rarely affect the hematological system. So check for ESR and the CRP. In fact, these are the inflammatory marker. The strange thing is that in the patient with lupus, unless patient has synovitis, joint swelling, or infection, usually the CRP is normal. The ESR will be raised only. So ESR usually start to rise within 1 to 2 days, return to normal within 4 to 6 days. CRP, it is very quick, start to rise within 6 hours, return to normal within 48 hours. You will check urea, electrolyte, creatinine, liver function test, do the urine dip, check for hematuria, proteinuria, especially if the patient is suspect of having SLE. It is very important to do the urine dip. So based on the patient symptoms, we will request ANA for every patient, ENA, double-stranded DNA, complement protein, serum protein electrophoresis. We will do it if the ESR is raised out of proportion to CRP. Rheumatoid factor, anti-CCP, we will order if we suspect the patient has overlapping rheumatoid arthritis. If we suspect the patient has myositis, and then we will request for myositis-specific antibodies. This is the nasal capillaroscopy. We will do if the patient is has renal phenomenon, and we suspect the patient might have systemic sclerosis. So these are the normal NAFO. It is like very parallel hairpin appearance. These are the features found in patients with systemic sclerosis. You can see megacapillary, giant capillaries. So in terms of treatment, it depends on the patient's symptoms, organ threatening or not. It also depends on the organ base as well. So we will use steroid, low dose, moderate dose, or the high dose, very high dose. Low dose means the dose less than 7.5 milligram per day. Moderate dose, 7.5 milligram to 40. High dose, 40 to 100. Very high dose, more than 100 milligram per day. Usually it means for parts IV methylprednisolone. So we have oral anti-rheumatic drugs and the biologics. So hydroxychloroquine, methotrexate, sulfasalazine, leflunomide. Usually we use it for patients with mild to moderate disease activity. Maybe we use for azathioprine and the mycophenolate tacrolimus for moderate disease activity. Cyclophosphamide, we use oral before, but we rarely use oral cyclophosphamide now. We use IV cyclophosphamide. It is reserved for life-threatening conditions, very severe disease activity. So let's say if the patient has present with like neuropsychiatric manifestation, SLE patient with cerebritis, SLE patient with transverse myelitis, we might give pulse IV methylprednisolone together with IV cyclophosphamide because the action is quick. But we need to be aware that cyclophosphamide, they can affect the ovary. So beware that, especially if the patient is like young people. In terms of biologics, we have cytokine directed therapy, B cell directed therapy, T cell targeted therapy. Um, the major biologics we use for connective tissue disease is rituximab. In SLE, we can use B-cell growth factor inhibitor, belimumab, but I think the rituximab is the most common used biologics in patients with connective tissue diseases. All these biologics can be used in the rheumatoid arthritis, mainly for the arthritis. But rituximab can be used in the lupus patient, Sjogren's syndrome, inflammatory myopathy, systemic sclerosis. So actually the treatment depend on the severity of the disease and organ system involvement. So this is my last slide. Do you have any questions? Do you have any questions regarding my presentations or do you need any clarifications? Do you have any case to discuss with me? Like, the case you saw in the ward or something like that? So if there is no more question, I will conclude my teaching section here. Okay, thank you everyone for attending the lessons. I hope you have some information regarding connective tissue diseases, and that will be helpful for your exam for someone who has not been tried for the MRCP. Okay, thank you. Have a nice day.